Hello everyone. Now I will discuss question of respiratory system. So we are getting a 32-year-old lady who come to you with sudden onset of dyspnea with right-sided pain chest and hemoptysis also. And while she was getting up from the bed, for the last 4 days she had a diarrhea as well as nausea, vomiting after eating in a new restaurant. The patient feels weak and thought her respiratory system was due to being in bed and inactive. Her chest pain increased with deep breathing, something unique about it. Well, she's a known case of HIV, heroin use, and prior episode of cellulitis in the right arm. Patient last CD4 cell count 2 months back was 350. And PPD at that time showed 2 millimeter of induration. It's very. PPD is for tuberculosis, so-called tuberculin tests. Okay. Well, she has a 15-pack year of smoking history. Temperature is, she's febrile at the moment. And the tachycardia is there, mucous membrane are dry. That could be due to she has diarrhea and that lead to dehydration, and that's why maybe tachycardia also, maybe a contributing factor. Of course, fever is also there. Breath sounds are normal, no crackle, no rhonchi. Chest CT scan is shown below. Well, if you look into chest, you are getting definitely a wedge shape opacity we are getting is there. Something unique. Which the following is the most likely diagnosis in this case? Well, the answer is pulmonary thromboembolism. Well, I showed you this is the opacity, wedge shape opacity is there. So, the patient symptom or the clinical scenario goes in favor of pulmonary embolism. What are the features? Acute onset of dyspnea, pleuritic pain chest. Her pain chest increases with deep breathing. This is a classical feature of pain of pleurisy. And if the patient due to this reason, whenever patient will have pleurisy, maybe on the right side, patient will tend to bend on the right side, and patient will try to take a deep breath on the left side, because the moment patient take a deep breath, the two inflamed layer of pleura, they will rub against each other and they increase the pain. So that's why patient automatically has a bending toward the pain side of the pain. Hemoptysis and tachycardia is there. Low-grade fever and mild leukocytosis are also common in pulmonary embolism. Like in our patient also, patient has a fever. Tachycardia is in fact one of the most classical, most common finding in ECG. Is the most common finding in ECG. Now this patient is increased risk of thromboembolism. Why? First of all, HIV. Patient CD4 count was 350, and hemoconcentration because of dehydration in the setting of recent gastrointestinal. Patient has a diarrhea as well as nausea, vomiting after eating in a new restaurant, and she really has dehydration that's supported by the dry mucous membrane. This one line is good enough to confirm the patient has dehydration. As I told you, the tachycardia is also contributed by dehydration also. But now I have a question for you. Stop the video, write down the answer. Why hemoptysis occur in pulmonary embolism? Stop the video. This occurs due to pulmonary infarction. Well, embolism is there that can lead to pulmonary infarction, and that's the reason why hemoptysis occur. Well, CT scan finding has been given to you, and that shows wedge-shaped pleural base opacity. This is a very important point. Don't forget this. It is, look, this is the wedge shape like this. Pleura base is toward the pleura, and this narrow is on the inner side. Again, let's visit the like this what I was talking to you. Okay, it's like a pyramid. The base is toward the pleura and the edge is toward the hilum. So with this background, well, we can see as a Hampton hump. Infarct area can also be seen in chest X-ray as a Hampton hump. You can see this is the Hampton hums in chest X-ray. On contrast CT scan, the pulmonary embolism itself will appear as a pulmonary arterial filling defect. And well, in the CT, it also shows the pleural effusion also. Let's see this is the typical what we are getting itself, and we are getting some amount of effusion also. Okay. Now let's look into other option. What about bacterial pneumonias? Bacterial pneumonia, they come with the fever, progressive increasing pain, chest, chills, cough, dyspnea. Symptom onset is less likely to be as dramatic because sudden onset dyspnea is different. Pneumonia doesn't have a instantaneous, it has some time frame is there, not as sudden. Hemoptysis can occur, but it is uncommon. Breath sound are normal, no crackle or rhonchi. That's one point, goes strongly against pneumonia. Okay, although in very initial pneumonia, this can be normal. But still, however, nothing to that least definitely goes against pneumonia. Alveolar infiltrate can be seen on chest X-ray, and CT scan will not reveal wedge shape as we see in this case. So this pneumonia is ruled out. But again, I have a question for you. Stop the video, write down the answer. Tell me which finding can be seen in the lips of a patient of streptococcal lobar pneumonia. We know very well this is the most common cause of community-acquired pneumonia. Community-acquired pneumonia. My question is, what finding in the lips we can see in case of streptococcal pneumonia? Stop the video. The answer to this question is patient usually may have herpes labialis. Okay. Now let's look into other option, lung cancer. Lung cancer can cause cough, pain, chest, dyspnea. They can also lead to hemoptysis. Imaging can be shown to have a round or spiculated mass rather than peripheral wedge shape. This is typically of pulmonary embolism. And onset is never sudden onset. Well, before I proceed further, I may ask you a question. Stop the video, write down the answer. The question is, well, I told you 4 symptoms of lung cancer. 1, 2, 3, and 4. Out of this, which of the 4 out of the 4 with the commonest presenting symptom of lung cancer? Stop the video, write down the answer. Well, most of people go for this answer, but this is the most common wrong answer. Answer is cough. Most common presenting feature of lung cancer is initially is cough. Okay, well, I'm sure you must have done correct. Now let's look into this. This is a typical finding what we get in chest X-ray. We get finding in imaging. Okay, so we are getting a round shape. We are not getting typical this finding toward the base. What about pneumocystic pneumonia? Is it seen in patient of HIV? Well, it's a strong indication. You must have thought because of HIV, but it typically when occurs CD4 count is less than 200. But in our case, it is 350. Of course, this reading is 2 months back, but we presume as of now. And moreover, it doesn't show, one thing is very clear, even this doesn't have a sudden onset. Sudden onset in all the option, if you look into, the only condition where we have sudden onset is pulmonary embolism. So this one line itself ruled out all other if you go by rule out technique. Well, moreover, imaging shows diffuse interstitial pattern, right? With now, again, I have one more question for you. Stop the video, write down the answer. Which enzyme is always raised in pneumocystis infection? Stop the video, write down the answer. Answer is LDH, is always raised. Okay. So now let's look into what, this is the pattern we get in pneumocystic. Interstitial pattern is there. So this cannot be. What about pulmonary tuberculosis? HIV, again, a risk of pulmonary tuberculosis. And the recent negative PPD is False negative PPD is unlikely in a patient with CD4 cell count of 350. It's a very, very important line. In HIV patient, PPD is false negative, but that when the CD count goes down very low, at 350, it is not false positive. Moreover, TB never has a sudden onset, very clear cut. Even regarding TBM, TB meningitis also, the patient has a short history of 2 or 3 days, the problem, headache, fever. It is definitely not a case of TBM. TBM also never come with a sudden onset. Same with the lung tuberculosis, never. They have always have a long history for weeks or months, not sudden. Pulmonary tuberculosis typically does not show a wedge shape. So what finding we get? This is a typical X-ray finding of TB. Okay. So in fact, golden line to remember, classically present with sudden onset dyspnea, and it's the most common finding, most common presenting feature. Pleuritic pain, chest, cough, hemoptysis, CT scan shows a wedge shape infarction. In fact, if you get these two lines, two words, 1 and 2, if you are getting this in any question, 99.9% you are dealing with pulmonary embolism. Golden words to remember: sudden onset of dyspnea with wedge-shaped infarction, and the typical finding I told you, this is pulmonary embolism. Subject made very easy for you. Thank you very much.